So my first speaker online is Vijeth Iyengar. Morali, did I say it right? Iyengar. Yes. And I got all excited. I was reading your speaker's background and everything. So this is one of those, although he's highly qualified, psychological background, doctorate, but he is coming to us from AARP. And many meetings that you go to, our real consumers are our patients, our subjects, and the people who work with. So I hope that this talk, Achieving Equity in a Healthy Aging, Global Insights from AARP, Aging Readiness and Competitiveness Initiative. Thank you.
Well, it's wonderful to be virtually joining you today. I want to thank the conference organizers, Duke, NIH, NIA, the Alzheimer's Association. I also want to thank the conference participants. I had a chance to take a look at the agenda for both days, and it's been a rich, robust, and comprehensive slate of talks. I want to thank and particularly Murli for the invitation. And you all know Murli, if he invites you, you got to say yes. And so it's a real pleasure to be joining you all virtually. Sadly, I wish I was actually on campus, especially today being a March Madness Tuesday with Duke playing a game tonight and me being a Duke alumnus, but we'll be cheering on them from afar. So today's talk, as Dr. Hussain mentioned, it's Achieving Equity in Healthy Aging, Global Insights from AARP's Aging Readiness and Competitiveness, or AARC initiative. I want to make a quick plug, but wholly relevant to today's agenda. Over the past 2 years, I've been working with two colleagues, Dorothy Gallagher Thompson out of Stanford University School of Medicine and Martina Izar from the Boston VA, on a special issue for the clinical gerontologist looking at brain and mental health in underserved populations. And it's quite timely because last week, the special issue was released in its entirety, and certainly entitled on cross-cultural strategies to address brain and mental health in underserved populations. It's sort of a 2-year labor of love. And I was excited at the opportunity to present this, or to share this resource rather, to this meeting. We provide some of our perspectives in our introductory editorial note that I'll hit on some aspects in today's talk, but certainly encourage all of you to take a look at the special issue, get in touch with us, let us know what we might have missed and what we might have gotten right. But just wanted to plug this in at the very beginning, if you'll allow me. So in the time that I have a couple of objectives that I'm hoping we'll get across. One is to boost awareness of global demographic trends, initiatives, and programs related to healthy longevity or healthy aging. A lot of the program has focused on, and rightfully so, on ADRD. What I'm hoping to do with this this time that I have with you is to present some perspectives on healthy aging. The second objective is sort of advanced understanding of the ways in which AARP is working to achieve this. I know some folks are familiar with AARP, some aren't. I'm thinking the vast majority aren't familiar with our global efforts, and so just want to touch very briefly on that, and then use the bulk of the presentation to look at how we define equitable healthy aging. What are some of the systemic, macro and micro factors that are driving equitable healthy aging, and conversely inequities in healthy aging across the world, and then really highlight some solutions that are ongoing in low and middle income countries that we in the US and other high income economies can learn from. So a snapshot of an aging demography, then proceeding to who AARP is, what we do, how do we engage globally, and then talk about the AARC 4.0, and sort of go through some of the elements of that report that we released in early February of this year. So we live in an increasingly aging society. This is a map from the WHO showing the proportion age 60 years or older. This is about 10 years ago now, in 2015. And you can see that the vast majority of countries around the world are in some degree of light to moderate red. You'll see that there are regions globally, specifically Africa, that are experiencing youth bulges that have very low proportions of their population age 60 years or older. This will change. So if we fast forward to 2050, the majority of the map is in darker shades of red. And we see that Africa, which experienced the youth bulge, is now more gradations of red. And just driving home the point that in the decades to come, population aging, demographic security are going to be increasingly important issues, both from research, policy, and programmatic points of view. So let's go a little bit deeper into these trends globally. Well, in the US, the proportion of 65 and over will, of course, increase from 2012 to 2050. This is some data from the US Census Bureau. We see that this pattern sort of mirrors when you look at countries abroad, in this case, China, India, and Indonesia. Some countries experiencing more of a steeper incline than others. And then we see that there are some interesting trends that have already happened, the forecasts that have already happened. And so the black arrow here signifies that in 2018, there were more numbers of folks age 65 and over than under 5. And so we're already experiencing these demographic transitions, and it's imperative to ensure that everyone, regardless of socioeconomic status, regardless of geography, are able to age healthily where and how they would like to. Pre-COVID, a lot of these trends were receiving attention globally. So National Academy of Medicine, of which AARP was a co-sponsor of, they provided this global roadmap on healthy longevity. They also did a Catalyst Prize via their Healthy Longevity Global Competition. The UN released their Decade of Healthy Aging in terms of catalyzing opportunities across sectors to provide changes in terms of healthy aging. And we see that in a historic first, and this, again, this is pre-COVID, July 2019, that the G20 leaders finally recognized the importance of addressing healthy and active aging society. So there was a lot of global movement pre-COVID. We see that this still continues post-COVID, and that there are now opportunities, given the discussions on equity, on inclusion, to ensure that older adults are at the table, and that all older adults, regardless of background, are able to age equitably. So what is AARP's role in this globally? Just very briefly about AARP, we are founded in 1958. We're about a 65-year-old organization now, and really guided by this principle of to serve and not to be served. We have about 35 million members, the majority of which are in the US, and we offer membership benefits to anyone age 50 and over. So what do we do? You know, we're characterized within the building here in Washington, D.C., where headquarters are, as a fierce defender of rights at the local, state, and national levels for the 50+ population. And so how does that manifest? When it came to COVID, ensuring immunization equity, stimulus payments for individuals and small businesses, supporting family caregivers, the real backbone of the American healthcare system, protecting the financial resilience of older individuals, helping older workers and job seekers during and after the pandemic, and then fostering livable communities. And so many of you are probably very familiar with a lot of this work. We also have a research arm of AARP, which tries to drive policy actions through recommendations and insights. And so we have a separate public policy institute, and many of you are probably familiar with that as well. What I'm guessing few are more familiar with is our international efforts. And so we're governed by this belief that, you know, what we do for one, we do for all, members, non-members alike. And that manifests in a couple of areas. One is by equitable design. The others by thought leadership, whether it be looking at the global longevity economy, chronicling older adult contributions to GDP, partnering with the World Economic Forum or OECD on unlocking the power of the multi-generational workforce, bringing private sector on board, and what I will talk about in a couple of slides, ways in which countries can equip themselves to foster equitable, healthy aging. We also have a journal, it's called the AARP, the journal, where we focus on particular areas of the world and see what they're doing and see if they're leading solutions, promising models and practices that we can bring to the States. In the most previous edition of the journal, we focused on Latin America. And as you can see here, the topics range from age-friendly communities to reverse innovation and what solutions we can bring from abroad to the States. And so to the bulk of the presentation, I just want to take a couple of minutes as to talk about what the Aging Readiness and Competitiveness Initiative is. And so this has been a multi-year effort within AARP, recognizing trends in population aging, the importance for demographic security, fiscal and monetary pressures that are being placed on countries to ensure that they are responding to the needs, support and otherwise of their aging populations. We created this initiative in partnership with Foreign Policy Magazine and now The Economist in terms of trying to provide data insights, solutions, and real research around several topics related to healthy aging. So in 2017, we focused on a core set of countries that were doing remarkably well in terms of addressing their 65 and over population. In 2018, we focused on small and innovative economies, Chile, Costa Rica, Lebanon, Mauritius, and others in terms of how they were responding to demographic change. In 2019, we looked at innovation, anything from caregiving solutions to home and community-based services to financial security, what solutions were occurring abroad that we wanted to lift up. And then finally, which I'll talk about in the next slide or so, is our latest version of the ARC on achieving equitable, healthy aging in low and middle income countries. And so we released this report in February 2019 after 13 months of research with The Economist magazine, specifically Economist Impact. The research included landscape analyses, interviews with expert stakeholders across LMICs, low and middle income countries. It included data insights and gathering some analyses internally in terms of trying to look at what are the both enabling forces and resisting forces to equitable healthy aging in these countries. So how did we define equitable healthy aging? It's a relatively new term. And so we operationally defined it in the report as a means by which all individuals have a fair and just opportunity to optimize health and well-being at all life stages. And so it takes a life course approach. And that is something that we emphasize in the report. Additionally, we mentioned, as I mentioned, requires a life course approach, and critically, achieving equitable healthy aging would manifest or involve reducing or eliminating social and structural disparities people experience throughout their lifetime. So the accumulation of inequalities experienced throughout lifetime that would lead to disparities in healthy aging after 50 or after 60. Critically, we focused on healthy aging because globally there are 3 or 4 instruments by which there was great alignment with the need or the desire to achieve equitable healthy aging. And so just go through these very quickly. We have last year we celebrated 20 years of the Madrid International Plan of Action on Aging, the first real global instrument for healthy aging. We have the UN Sustainable Development Goals, as I mentioned, the UN Decade of Healthy Aging. And so there was great alignment in terms of, if our goal was for this report to catalyze movement globally, we want to ensure that we were choosing a topic for this latest version of the ARC that would align with what is being experienced globally. So you might be saying, AARP is a US focused organization, all your members are in the US. Why should we focus on LMICs? It's a good question. Well, I think there are opportunities. The data that we uncovered speaks to the opportunities as to the why. And so the percentage of population in this first figure, you see that there are 4 circles, lower it based on World Bank economic classification from lower income countries to the deep red being high income countries. And so this shows the percentage of population age 65 and over in 2050, and the growth rate in percentage. And if you look at countries based on their economic classification or by region, what is clear is that whatever rapid growth in demographic aging the global experience will be driven by low and middle income countries. Specifically, sub-Saharan African countries will experience the fastest growth, while Asian countries will contribute to over 70% of global increase of the older population. So we wanted to look towards what the future will hold, not Western Europe or North America, but rather where demographic shifts will take place the most, and then be able to provide insights to then inform how governments respond to equitable, healthy aging. Now, the challenges for equity are both, and this group knows well, both in high income countries and low and middle income countries, or LMICs, but they're more acute in LMICs. Some of the factors that we uncovered, that they're really large informal economies. There's constrained financial capacity. There's insufficient public institutions and just a real lack of political will. And this was echoed by CEOs and other executives that were interviewed by the report. This is a pull-out quote from the CEO of the Inter-American Development Bank's Innovation Lab. And it drives home the point of the report. And one of our takeaways is that equity is not just a US problem, or it's just not just a developing problem, a developing world problem. When it comes to equity, we're all developing countries. And that's one of the takeaways that we wanted to focus on in the report. So what were the goals? Was to examine, for the report, was to examine how inequalities accumulate across the life course, highlight some of these solutions and leading practices to combat aging inequity, and then be able to recommend actions to address aging inequity and help fill some of these knowledge gaps. So what are the factors that drive inequities in LMICs? What did we uncover? And some of these will make real common sense because it's some of the same factors that we're experiencing here in the US. First, we found gender disparities that prevent equitable, healthy aging. This is a busy sort of bar chart, but basically it separates by on the Y by economic classification, the gender, men and women. The take-home point here is that across countries of different income levels, women tend to live longer than men, but in more years of poor health in later life, which is one thing that we wanted to emphasize. It's not just looking at curbing inequities for longer life, it's more the health span rather than just the lifespan. So there were gender disparities. Second was real rural-urban divides that were bifurcating the aging experience. So, and some of the data shed light into this. And so by 2030, 3 billion of the world's population is going to reside in rural areas, 95% of which are in low and middle income countries. And part of these divides include unequal access to social protection and healthcare, divided informal employment, and unequal access to educational opportunity. We also looked at data deserts, and I know that was one of the themes that Dr. Hussain and the agenda touched on. And to no surprise, data deserts are going to drive inaction for policy solutions. And so they're more acute in LMICs than what we experience here in the US. What we found was globally, only 32% of countries have nationally representative cross-sectional data. This is more importantly, if we look at longitudinal data, the number goes down. And only 24% have longitudinal data on health status. Now, that makes it very difficult to be able to track healthy aging or disparities in late life if we don't have this longitudinal data. Critically, as is experienced here in some pockets of the US, there's also disaggregated data by both age, race, and ethnicity, and they're lacking in most low and middle income countries. Now, it's not all bad news bears. We wanted to also highlight solutions, as I mentioned. And so we had these solution spotlights in the report. Now I'm running out of time, 5-6 minutes left. So I'll just be very quick in saying that we highlighted two programs that were promising, evidence-based, one in Ethiopia, one in Colombia, that helped bridge the divide in healthcare access in rural areas. In the interest of time, I won't go into the specifics, but just note that they took advantage of community health workers that were trained to serve as liaisons between healthcare professional staff and community dwellers in terms of being able to bridge those access divides. There's also some data points of light. And so China, for example, the China Health and Retirement Longitudinal Study, Charles, aims to build a nationally representative database on a range of factors. And so there's some promising trends. And in India, we noticed longitudinal aging study in India, so a full-scale survey that includes social determinants and consequences of population aging. That's great. So we talked about the challenges. What are the barriers to sort of unleash progress in LMICs? And I touched on it before in a couple of slides. First is to hit on the point about a lot of the economies and a lot of folks that are employed in these LMICs are actually informal economies. And so they're not in the formal labor market. And so this graph depicts the percentage of folks informally employed in the red, formally employed in the beige, for both the world, low and middle income countries, and high income countries. And I think hopefully what's clear is that what makes it different is that 30% of low and middle income countries are formally employed, 70% are in informal employment. Compare that to high income countries. And you can imagine if you're informally employed, you don't have access to health insurance, you don't have access to a lot of the benefits that do come with employment. Social protection systems are not as robust as they could be. Low income countries are in gray, lower and middle income are in orange, high income, such as the US, are in red. So if we look at population, the percentage of populations covered by at least one social protection benefit, or persons above retirement age receiving a pension, or if we look at those that are vulnerable covered by social assistance, or lastly, those unemployed receiving unemployment benefits, we see that higher income economies are doing well, low and middle income countries are not doing so well. And so there's substantial gaps in both coverage and adequacy of these social protection systems. In turn, public health systems are not as developed as they should be. And so if you look at both population covered by a social health scheme, the percentage, as well as out-of-pocket expenditures, they're going in reverse directions. LMICs overall see a significant gap in their health systems, included limited population coverage and financial protection. We also have additional barriers that we're also seeing here in the States. One is just legislative policies are lacking in political will. We see that, just to speed through this a little bit, that their traditional informal networks of care are weakened. Given the global mega trend of aging, we also have something of rapid urbanization. And so these care networks and caregivers, the dynamics have changed rapidly. And as a result, the care economy and these networks of care have been weakened. And another barrier is educational systems across the board. We also highlighted some solutions in terms of what are some stopgap measures, one in Serbia, one in Bangladesh. Again, in the interest of time, we'll skip over this. So this is a very busy slide, but just it goes to show that if one is interested in the audience in looking at the types of innovations that we highlighted, that we went over by category, it's available at the report. Certainly happy to share a link to that as well. But we looked at innovations for cash transfers to look at economic empowerment, innovations to help improve access to healthcare and home care, healthcare financing, and self-support and self-advocacy. And so if you think about it, we sort of did a comprehensive overview of all the solutions and the topical areas that would be impacted rather by systemic, either at the macro level, micro level inequities, and what are the solutions being able to that have been employed and at scale in these countries to be able to help curb those inequities. So what can we do, right? I gave you a bunch of challenges, right, in terms of barriers. And so we did have some calls to action by sector. So the public sector, there could be refinements in existing physical and institutional infrastructure, greater investments in both data governance, data collection, design and implementation of stronger comprehensive national aging policies. In terms of civil society, which is AARP is a civil society nonprofit organization, we should be continuing to beat the drum about some of these issues and help inform both our advocacy efforts and collaborations, both here and abroad. At the individual level, a lot of resistance from LMICs is ageism, right? Ageism prevents research recruitment into clinical trials or older adults in plans for, say, emergency assistance. And so building more age-friendly societies can help boost equity at both the county level, community level, and national level. And the private sector, there's some concrete recommendations to incorporate age into DE&I policies or address employees' health and well-being. And there are all sorts of policies that we put forth in the report that the private sector in particular could do. So just very closing, some takeaways. Rising inequalities are a global challenge. If anything, COVID has shone a light on that. Not just a high income, not just a low and middle income country problem, but a truly global challenge. Equitable healthy aging is achievable, but requires utmost sustained commitment from governments. There's a heterogeneity of disparities. Not everyone ages in the same way or same manner. Older adults are not a monolithic group, and certainly better efforts in terms of data collection, governance, analysis, recruitment, all hold great promise. Adopting a life course approach is imperative. If one wants to age healthily, one should invest in healthy living and systems and structures, supports early on. And then lastly, as I mentioned, policy will continue to work in the dark if there isn't data or evidence to inform it. And so with that, really appreciate the time. I want to thank, again, the conference organizers for this opportunity. If you want to learn more about the ARC and some of this report that I sped through in the time given, there's a website there, and certainly you can reach out to me. Thank you very much.
Great. Thank you very much. Outstanding.
If I can ask a question.
Sure. So
So there is a question online. If you can go over slide 7 and the fourth figure on the right hand lower quadrant, that would be great because it was not discussed.
Okay. Is it this figure here, or?
Right. It said right lower section.
pretty much, I think so.
Regarding with the to COVID, I think.
Was it this?
Yes, slide 7. That is the one.
This one.
Yes.
Okay.
And what is the
Okay.
question? Regarding-
I just want you to go over it again, I guess, because it was skipped in discussion.
Okay, so let me, as the chair, I think what was most striking even to me on this slide was on the left lower, where you see the cohort, which is 5 years old, and versus the one which is increasing in age. Can you describe it a little bit further, and how would it impact as we move forward?
Yeah, I think, well, I appreciate the question from the chat. Yeah, so this is really pivotal Census Bureau data showing an inflection point in 2018 that occurred where there were more number of folks 65 and over than less than 5 years of age and under. This has great policy implications. First, I think this is a data point we use when convincing state governments, federal government, that aging is important. that they should invest in systems to boost healthy aging. This is a data point that we use for funders and for partners. Part of the reason, and the audience might know this, part of the reason is population aging is still low on the policy priority agenda for countries. And it's low on the policy priority agenda for countries. It's because not everyone is experiencing the demographic shifts uniformly. Western Europe, South America, North America have already experienced it. And so data like this, they say, okay, duh, we get it. But data like this is critical for, say, Southeast Asia, for Western Asia, Western Pacific, the Middle East, Africa, where they're experiencing youth bulges. They haven't experienced a demographic shift, but they will in the next 10 to 15 years. So the argument we make to either the World Bank or other development financial institutions is, please invest in older adults now. Please invest in the cohort now that will age in the coming decades, because we've already surpassed the period of time where there are more number of folks 65 and over than less than 5. And so it doesn't make sense to ignore aging, given that population demographics are telling us, and projections are telling us, that there are more and more number of folks going to be reaching these advanced ages as a result of advances in medical science and technology and healthcare access, service, and delivery.
Sure, thank you. Just last question, Dr. Trusami.
Vijeth, thank you so much for this very insightful presentation. And next time, I hope we can bring you here to Duke.
Sure.
So a question, two of the themes here are how can we increase diversity in clinical research studies, especially clinical trials for preventing things like Alzheimer's? So the first question is AARP doing any work in this area and collaborating with any large registries or anybody like that to increase diversity in clinical research studies? And the second is there an arm within AARP that's looking into developing new data methods and new data analytic tools for addressing issues related to aging?
Second is, it's a bit nuanced, but I would say the broader question is yes. We have an AARP research arm. We have partnerships with the University of Michigan, which is a different shade of blue than Duke. But the way, from my understanding, right, and this is a large organization, the way that we've affected change or contributed to data information gathering is through survey research. And so the National Poll on Healthy Aging, or NPHA, is in partnership with the University of Michigan, and we fielded nationally representative surveys across the country on topics as diverse as brain health to drug use in the 50+ population. That has served us critically well. It's publicly available, but it's informed our understanding of both policy insights and prescriptions and recommendations. To your first question, that's something I'd have to look into in terms of what AARP is doing specifically, either through partnerships or through advocacy efforts to diversify the recruitment and participation of the clinical trial population. I want to say enterprise-wide, acknowledge that is indeed a challenge, and there's an opportunity there. But I'm happy to come back to you, Murli, in terms of what we're doing specifically and if there are opportunities for partnership.
Great, thank you very much.